Your next exam is going to cover upper and lower GI. So we're going to start with the upper first. All of these PowerPoints that I'm posting for GI are going to have quite a bit of videos in there and some supplemental information. So I'm going to upload a separate PowerPoint without the voiceover because in the online recordings, I can't click on these and have the video play for you in a manner which you're going to be able to hear it. It has a lot of distortion that way. So make sure you're looking at the other PowerPoints with all of those embedded videos in it. So I decided to go ahead and leave a couple of these slides in here to maybe help you correlate how these sections are going to relate to your nursing assessments and care. So with GI, we have a nutritional metabolic issue. So these are going to be major diagnosis with manifestations. They're going to affect consumption of foods and fluids, and a lot of times we have to get dietaries input with this as well as dietitians. It's going to affect the ability to heal and really their whole body. So common nursing diagnosis you will see here is going to be impaired skin integrity. We saw that with the last section because people with lower protein levels have a tendency to not heal very well. So if they've got pressure injuries or any other type of surgical incisions, abrasions, and so on, you really want to take a look at their nutritional status. So risk for infection, deficient fluid volume, that's kind of a given if they have lack of hydration. Disturbed body image, that's going to be a huge thing. Think about your people with anorexia. Bowel incontinence, constipation, diarrhea, electrolyte imbalances, of course. And think about your stroke patients. They could have impaired swallowing, and then, of course, hyperthermia and hypothermia. So terms to know. I know I mentioned this in that study PowerPoint that I gave you, but really these terms are going to be things that you would have learned in a previous semester that I'm not going to go through and explain them to you, but you'll still need to know them. You will see them as terms that appear on your exams. You'll see me using some of these throughout the lecture content for GI, upper and lower. So just be aware of them. So first we're going to cover common disorders of the mouth. So the blanket term I'm going to use here is stomatitis, and that's really an inflammation and ulcers of the oral mucosa, and they're pretty common disorders of the mouth. The most common cause is going to be a viral infection. So others could be bacterial or fungal infections. They could be mechanical trauma, like when you bite your cheek or your lip, irritants such as hot and cold foods, tobacco use, ill-fitting dentures. Also think about other types of dental appliances besides dentures, like partial palates, retainers, and so on. Braces, it's another big issue. Nutritional deficits and chemotherapy agents. Chemo is notorious for causing stomatitis. So individuals with immunosuppression are at risk for stomatitis, those with HIV, cancer, and of course diabetes. Other things to consider, and I will really stress this to you, especially with the GI tract, antibiotics. Antibiotics really disrupt that normal flora of bacteria and can cause quite a few issues. Anticholinergics do as well, so do corticosteroids, and poor oral hygiene. So your manifestations here are going to be dependent on what is causing the issue. So it's diagnosed by direct physical examination, cultures, or an evaluation for a systemic illness. A lot of times, especially with something like this, you can see this patient has some thrush. Every time I see this diagnosed, it's because the nurse has seen it while they were doing cares, or the CNA has seen it, and then we present that situation to the physician, and they'll get them a treatment ordered. So the treatment is going to be meticulous oral hygiene, topical medications, and sometimes antibiotics depending on what the cause is going to be. You want to avoid alcoholic mouthwashes because they're going to cause burning. When you're doing your oral care on these patients, we do have those little green swabs, and they kind of have a mint flavor to them. I would start off with something light like this because, this can be really quite painful, and it recommends to use a soft toothbrush and flossing, but really those little green swabs first, initially in the beginning when they're in the hospital, are preferred. You could use a saline solution or sodium bicarbonate, like baking soda, to promote cleaning in between meals. And they have this stuff called BMX solution that we give in the hospital. It's a radiotherapy mixture, and it's equal amounts of Benadryl, Maalox, and xylocaine, and that just kind of helps numb the area. So with something like this, if you're giving a BMX solution in the mouth, you can see that this is pretty profuse in the mouth, and you can't see down the throat, but it's likely to be down there as well. They can swish and spit that out, or swish and swallow it. It is quite numbing. I've used it before myself, and it's going to make the whole mouth numb. So if they only have a sore, say, over on this part of the mouth, you can paint that BMX solution over there so it's not making their whole mouth tongue and their tongue numb. So for fungal infections like thrush, for this, you would treat that with nystatin. That's that oral suspension that you swish and spit or swish and swallow. And for viral infections like herpes, they would treat that with oral or topical antivirals like acyclovir, Famvir, or Valtrex. Bacterial infections are treated with antibiotics, and that's really going to be based off a culture. So if you weren't sure that this was thrush, like say you contacted the doctor, they ordered the nystatin, and the treatment wasn't working, they're probably going to take a culture next. So initially they don't really culture with thrush, but if the treatment's not successful, then they would. So for something like this that still doesn't clear up, and even after a bacterial culture, sometimes they will do a skin biopsy. However, I have not really seen that often. So again, this is thrush. So this one right here, that's going to be oral cancer. So usually this is going to be a squamous cell carcinoma. This is pretty uncommon. It only counts for about 3% of cancers. It does, however, have a high rate of morbidity and mortality due to metastasis, and it often occurs with the people that are over the age of 40. So the primary risk factors for this are going to be smoking, drinking alcohol, chewing tobacco, marijuana use, and occupational exposures to chemicals, as well as HPV. So this one is going to frequently metastasize to the lymph nodes. And if you think about where this is located on the tongue, it's quite close to the neck. So it's going to go to a sentinel lymph node there. So later symptoms are going to be difficulty with speaking. You think about this getting larger and really affecting the tongue. It's going to affect swallowing and chewing, and you may see the lymph nodes swollen or even blood-tinged sputum. So with something like this, one of the primary things you're going to do is eliminate the causing factor. So if your patient smokes or chews tobacco, you're going to get them on a quit program. You're going to do a biopsy, and that's going to allow a visualization of the cells to determine the presence or absence of cancerous cells. Now this one's probably pretty clearly going to be a tumor, but there's going to be some cases that are questionable, so they always want to make sure they do a biopsy first. They're going to do a CT, a CAT scan, MRI, and that can be required for further diagnostic assistance, and that's going to determine if there's any metastasis, possibly a PET scan as well. So treatment for this is going to be radiation, surgery, chemotherapy, and that's going to be the treatment of choice. But this is often based on the functional and cosmetic result of the treatment. So some tumors are quite aggressive, and they require a combination of these or all. So if you've got something mild that is not very extensive, they might not need chemotherapy, but remember, these often metastasize because they're caught late. A tracheotomy might be needed if the lymph nodes are involved and the muscle tissue has to be removed. Think about all the structures in the neck and how close it is to your airway. So sometimes they do end up with a tracheostomy. So another thing to consider with these, if the tumor involves surrounding tissues, they're going to have a lot of cosmetic effects of surgery, and it's important to consider that. The neck muscles are going to be affected, so they might need some PT and OT, and definitely a consult to cosmetic surgery. Most of the surgeons that will operate on something like this are going to be specialists, like an ENT surgeon, so they may automatically do that. This one right here is just another picture of a different location and a different type of oral cancer. Some of your nursing interventions are going to be an effective risk for ineffective airway clearance. And when I talk about these, I really want you to think about why. So for ineffective airway clearance, we've got a lot of swelling after surgery. So you want to make sure that you're maintaining your airway. You're going to observe for patency, monitor their vitals. You want these patients in a Fowler's position, and that way you can support them so they can cough effectively and maintain adequate hydration and humidity to keep those secretions then, because they do have quite a bit of secretions after surgery. In balanced nutrition, you're going to weigh these patients every day because that's the most reliable indicator of their fluid volume status. You're going to collect I and O's on them, observe for adequate intake and output, serve soft and bland foods with supplements. These patients are having a lot of pain in their mouth, and there's not a whole lot you can do to help treat that while you're eating. So you want to make sure that you're supplying some soft foods with that and maybe get them something to help numb the area. They could be having enteral feedings via G-tube, and you want a dietary consult with them. The dietitians can really help out with different types of options for them. Impaired vocal communication, you're going to pre-educate these patients on using a plan to communicate with them after surgery, especially if they're going to have involvement with the tongue like we see in that previous picture there. So you can use a dry erase board, flashcards, computer. There's all sorts of different ways you can do this. That's going to help decrease the anxiety and fear that they're going to have with these surgeries. You want to give them time when communicating. It hurts them quite a bit to speak, and get a speech therapist on their case as soon as possible. Disturbed body image. So think about, this is in your face. You could have lymph nodes. It could be involved in your neck. Your appearance is going to be different. So assist them with their coping mechanisms, allow them to talk about it, provide emotional support. You might need to get psychiatry involved in this to help them out, and really support them. And just be aware too, secretions are also going to be an issue. So not only are secretions going to impact your airway, but they're going to impact your appearance. These patients, if you think about all the nerves that are involved in this area, they can lose function of their mouth, and drooling can be a problem, and that really affects the way that they feel about themselves. I already went all over these. So I'm not going to go back and re-record that, but we talked about these already. Okay, so GERD, that's going to be your gastroesophageal reflux disease. And we can have a number of things going on here. Relaxation of the lower sphincter, incompetent lower sphincter, or even a hiatal hernia. So because of the location, symptoms for this are going to mimic a variety of different illnesses. So this is going to be a common disorder of the esophagus. This is when gastric contents will reflux back into the esophagus from the stomach. Gastric juices, they're going to contain acid, pepsin, and bile. That's really quite corrosive, and it has no business being in the esophagus. So a prolonged exposure to this is going to cause esophagitis. And that esophagitis is really caused by chronic inflammation. So the lower sphincter relaxes and opens when it should not be, or it's not functioning appropriately, or there's increased pressure within the stomach. So those are going to be your three things that are going on. Factors contributing to this: increased gastric volume after meals, positioning that allows gastric contents to remain close to the gastroesophageal junction, and think about bending over or laying down. Sometimes after a meal especially, you'll tell these patients not to bend over too soon and eat a couple hours before bedtime. Increasing gastric pressure, obesity, and wearing tight clothing, those can all cause these to flare up. And of course, hiatal hernias. And don't forget about recliners too. Sometimes, especially after family dinners, I always think about Thanksgiving. You'll always go in the living room and you'll see all the guys sitting in recliners watching football. Inevitably, somebody ends up needing Tums because they've got some GERD and they laid flat too soon. So laying flat, you're positioning that really creates an environment where gastric contents remain close to that gastroesophageal junction. So your manifestations, they're going to have some heartburn, and that's the regurgitation of the sour material into the mouth. Dysphagia, that's your difficulty or painful swallowing. A lot of times they're going to have some atypical chest pain, pain after eating, belching or a sore throat, or even hoarseness. They could potentially even have some respiratory symptoms. If this leads to esophageal erosive esophagitis, this can occur when the mucosa becomes red, friable, and they can have superficial ulcers. The untreated esophagitis is going to lead to scarring and strictures. Diagnostics for this, they're going to have the patient do a barium swallow, and that's where they're going to swallow a barium solution that coats the esophagus, and that enables the hollow structure to be imaged through x-ray. They could also do a 24-hour ambulatory pH monitoring, and that's where a small tube with a pH electrode is inserted through the nose and down into the esophagus. The electrode is attached to a small box on a belt, and it records the data for about 24 hours. And these patients can do everything they normally would do with that probe in. They can go to work, they can eat, they can drink. And there's a video on the PowerPoint that is not a voiceover. So make sure you go to that PowerPoint and click on the different exams and watch them. So complications, we already talked about esophageal strictures, and they can also lead to Barrett's esophagus. And that's when there's a change in the cell lining, and that is a very high risk for developing esophageal cancer in the future. So this is where you will go on the other PowerPoint to watch the video on the endoscopy. So what we're going to be doing is endoscopy procedure. You have to have a consent sign for that. So think about when you're going back to what we covered in pre-op. So they have to have a consent. We do a checklist, and that procedure uses a lighted flexible endoscope to see inside the upper GI tract. So they can see down into the stomach and to the duodenum, which is going to be the first part of the small intestine. They can take biopsies for this as well. And your other patient prep is going to be NPO for 8 hours prior to this procedure. These patients are going to have conscious sedation, so they won't be put out all the way, but they also won't remember the procedure. They do a pretty good job of medicating them so they don't remember it. So look for your consent for procedures, do your checklist, NPO before midnight. That's going to be your key things. There's a picture of a pretty healthy looking esophagus. This is another really good video that you can watch on this procedure. So they're going to feed this little pressure catheter down here, and it measures the pressure of the esophageal sphincters and also peristalsis. So make sure you watch that. So treatment is really going to be revolving around changing in lifestyle choices to reduce GERD, and that's going to be that's always the hardest thing for patients, is changing their lifestyle. So you really want to encourage them to avoid acidic foods like tomato products, citrus, spicy foods, and unfortunately coffee. They want to avoid fatty foods, also peppermint, alcohol, and chocolate. Maintain good body weight, eat smaller meals, and refrain from eating 3 hours before bedtime. So that kind of talks about the sitting upright there. So you want to make sure they stay upright for about 2 to 3 hours. If they really do have quite a hard time even after they lay down, even if they've waited a long time, you could also elevate the head of bed. So that's pretty easy to do in the hospital. At home, not so much, but they could put some blocks underneath the head of the bed about 6 to 8 inches. You want to stop smoking and decrease use of alcohol. Avoid tight clothing and bending to relieve symptoms. Surgery may be indicated in severe cases, and that's when they are doing a fundoplication, and that's when the fundus of the stomach is pulled up and wrapped around the esophagus. That can be done laparoscopically or open, but just be aware that's going to be in extreme cases only. So medications. a lot of medications out there to treat GERD, and you're going to see in GI, some of these medications are going to overlap. So one of the best things you can do for that when you are studying is make a list of all the GERD or all the medications for GI, and put down which treats what, because there's going to be some overlap there. So H2 antagonist, this is going to decrease gastric acid production. There's a couple different options here. We've got ranitidine, famotidine. What you're going to see in the hospital more than anything, though, is going to be these proton pump inhibitors, specifically Protonix. These other ones are okay. It's just, for some reason, the hospital loves Protonix. So you'll see Prilosec and Prevacid 2 for proton pump inhibitors, and they're going to reduce gastric acid production as well. So antacids, not as popular in the inpatient setting, but they are available. A lot of times patients will take Tums at home, but these are going to be neutralizing your stomach acid. To me, this is more of a treatment afterwards, and these are more of a preventative beforehand. So antacids are going to be neutralizing your stomach acid as well as providing some pain relief too, so don't forget about that. And then promotility agents, your Reglans. This is going to enhance esophageal clearance and gastric emptying. And Reglan's used for a lot of different things, but it really promotes peristalsis here. So I think about Reglan as, if you've heard of the candy now or later, your antacids are now, your Reglan is later. So this is really treating in the immediate time frame. The Reglan is going to keep things moving, keep things flowing, and reduce complications from GERD. So, hiatal hernia. This is going to occur, you see one right here, when part of the stomach protrudes through the esophageal hiatus of the diaphragm and into the thoracic cavity. So it's really through that diaphragm. You've got the diaphragm here, this is the stomach, and part of the stomach is above that, and it shouldn't be. So most individuals with these are asymptomatic, but the symptoms increase with age. Your contributing factors are going to be weakened anchors of the gastroesophageal junction to the diaphragm, a shortening of the esophagus, or increased intraabdominal pressure. Sometimes these patients will end up with a sliding hiatal hernia or a paraesophageal hiatal hernia, and that's where the junction stays intact below the position of the diaphragm, but part of the stomach will herniate up through the esophagus, and it can become strangulated and impair blood flow. But that's going to be your worst case scenario. So manifestations for these patients, they're going to have some reflux and heartburn. They're going to have a feeling of fullness and substernal chest pain. They could suffer from dysphagia, have signs of occult bleeding, belching, and indigestion. Diagnostics for these going to be a barium swallow again, or an upper GI, and that's going to be done with the same type of precautions as the other GI, upper GI we talked about. So NPO after midnight, getting a consent sign, getting a checklist. So typically the treatment is going to be based off symptoms, so a lot of it's going to overlap with what we saw with GERD. Change in lifestyles, diet changes, medications, and potentially surgery if they need it. And that's going to be the fundoplication again. So esophageal cancer, this is going to be pretty uncommon in the United States, but your risk factors are going to be cigarette smoking and chronic alcohol use. There's going to be two kinds with this. That's going to be your squamous cell and your adenoid carcinoma. And even though it's relatively uncommon in the United States, it has a high mortality rate, and that's due to these symptoms not being recognized until later stages. Other risk factors other than smoking and alcohol are going to be ingested carcinogens, nitrates, processed meats. Think about your hot dogs and your lunch meats, your cured meats, bacon, salami, and sausage, as well as contaminated water, and that's due to fertilizer or waste. Industrial chemicals can also cause issues with this. Thermal injury from hot drinks or other physical mucosal damage, radiation treatment, congenital disorders. And the big one here is going to be your chronic gastric reflux, so your chronic GERD. Disease usually spreads by metastasis to adjacent and supraclavicular lymph nodes, as well as the liver and the lungs. Your most common manifestations are going to be progressive dysphagia and recent weight loss. Fistulas can also develop between the esophagus and the trachea, and that can cause aspiration as well as pneumonia. The cancer is often advanced when it is discovered and incurable at that time, because a lot of times they don't know about it until that dysphagia occurs. And the dysphagia doesn't typically occur until it's about 60% circumference of the esophagus. So if you're looking at this right here, 60% of that has to be occluded before they're going to start experiencing dysphagia. And that's quite a large tumor there. Fewer than 5% of these patients will survive to the 5-year mark. So diagnostics for this is going to be a barium swallow, upper GI, and a chest x-ray. They could also be doing a CT, an MRI, a CBC, and they're looking for anemia. Treatment is going to be involving surgery to remove this. They're going to do some radiation therapy and or chemo. So if they do a combination of chemo and radiation, that can be followed by surgery to resect the tumor. So that means if the tumor is large enough where they cannot remove it safely, they'll treat it with radiation and chemotherapy to shrink it before removal. And this seems to be more effective than any type of single treatment. Surgery is going to be resection of the affected portion of the esophagus. So that's when they're going to do an esophagectomy, and possible anastomosis of the stomach to the remaining esophagus. So that's going to depend on how much of this is affected. So if they're going to do an anastomosis and it's right here, they'd be cutting right there and attaching the stomach up here. If it's much farther up and there's a large amount of the esophagus affected, that might not be possible. So your patient might end up with a PEG tube. So when these types of cancers metastasize to any type of local distant site, they're going to be focusing palliative therapy to relieve some of that dysphagia and pain. Some of these include endoscopic dilation, wire stents, laser therapy, and those are really designed to keep the esophagus patent. They could also just be bypassing that by placing a GJ tube or a G tube or a J tube for feeding and fluids. I did take care of a gentleman once that had quite a large tumor in his esophagus, and it was metastasized, so they couldn't do much for him. But his biggest concern is he still wanted to be able to eat whatever he wanted. So they would just go down endoscopically with a stent and dilate this area by pushing that tumor back. And as long as he was able to eat, he was fairly happy. So here's another picture of it from the inside. You can see this tumor is quite large, and it has a couple other areas surrounding it. So this patient would definitely be symptomatic. So with this, we're going to focus on health promotion. We're going to educate the relationship between GERD and chronic damage to the esophagus. You really want to get those patients early with GERD to help prevent this from happening, since that's one of the #1 risk factors. You want to discourage smoking, get those patients on a QUIC program, and limit alcohol intake. So for nursing diagnosis, we see impaired nutrition. You think about this, they are not going to be able to get enough food in them. Liquids are one thing they might be able to eat, so if you get a dietary consult in there, get some supplementation for these patients. Ineffective airway clearance, especially after surgery, and that's going to relate to edema. So if they're able to resect this tumor out, which this one's pretty large, it's kind of hard to say. Think about how much swelling this patient's going to have, and this could be very little airflow right there. And anticipatory grieving, and that's going to be related to a poor diagnosis. Some of these patients will have quite a bit of grieving because they feel like they caused the cancer themselves because of that, because of the smoking. But just know it's not their fault. You need to communicate that to them. Okay, so GI bleed. The GI tract has a really rich blood supply. So when this happens, it can result in pretty significant amount of bleeding. think about any type of varices a patient has, esophageal varices. If they rupture, it's going to bleed significantly. So the GI tract is constantly exposed to trauma, toxins, infections, and inflammatory processes. So these GI bleeds, they can happen anywhere within the GI tract, but the most common place is going to be the upper portion. Think about those esophageal varices again. That's when the veins are really enlarged that form in the submucosa of the esophagus, and this is going to be common in your alcoholics. Other causes can be from erosive gastritis, peptic ulcer disease. That's about 50% of these cases, and then we already talked about the varices. So the effects in the GI tract are going to be related to a lot of different things. So nausea and vomiting, that's going to be related to the irritation of the stomach lining. They're going to have partially digested blood. That's going to be your coffee ground appearance if they do vomit. The accumulation of the blood is going to increase peristalsis. So you're going to see these patients have some diarrhea possibly. The stool may be black, tarry, or frank bloody. That really, the appearance of the stool depends on the level of the bleed. And once you smell this, you will never forget it. There's been times when I worked on the oncology floor, I'd walk on the floor and I would just know there was a GI bleed present. So just a little bit more on that. So upper GI bleeding, you're going to have digestion of blood and proteins. That is going to really increase your BUN levels, so be aware of that as well. So they're going to have a low hemoglobin, low H&H, high BUN. And the kidneys just have a really difficult time of processing the proteins from the digestion of the blood. Your manifestations are going to depend on how fast this happens and the magnitude of blood. If it's a small bleed and it's slow, it's eventually going to lead to blood loss, anemia. If it's a large bleed and it's rapidly depleting blood volume, they're going to be hemorrhaging. So the small bleeds, they're going to cause a depletion of iron stores. So they're going to have more than one type of anemia. They may not see blood in stools, but a hemoccult is going to be positive. So they'll be able to see that blood on a microscopic level. A massive bleed, a GI hemorrhage, that's going to be a medical emergency. That's a significant amount of blood loss within a few hours, sometimes even faster. So this rapidly depletes blood volume. This causes a decrease in cardiac output, tachycardia, hypotension, pallor, and decreased urine output, and eventually this leads to hypovolemic shock. So a lot of different signs with this, and again, it depends on how fast it's happened. I've seen it happen really fast. You'll see a decrease in blood pressure, a rise in your heart rate, a rise in the respiratory rate, decrease in O2 saturation. Just think about that decreased level of blood volume. So they have decreased oxygenation. They're going to be restless, anxious, and then eventually lethargic and unresponsive. So the treatment for this is going to be a massive amount of IV fluids, also blood, but you really do need to consider whether or not your patient is willing to accept blood. And that's one of the questions that we ask them when we first admit them. O2, we're going to put them on oxygen to help increase their O2 sats. Prep them for surgery, and you're going to do it quickly. So medication to increase the blood pressure, that's going to be dopamine and epinephrine. And then elevate the feet. So you want the head of bed down, and think about why. Where are you trying to keep that blood flow? You're trying to keep it to the critical organs. So elevate their feet and get them started on a regimen to prep them for surgery. Diagnostics, when it's a slow bleed, you're going to be doing a CBC, blood type and cross match, and again, check and make sure they're willing to accept blood. Serum electrolytes, you're going to look at their osmo, their BUN, liver function panel, coag panel. Some of these patients, they may or may not be on anticoagulants. A lot of times, especially with esophageal varices, that's going to be caused by chronic alcoholism. And upper GI, they're going to be doing that as well. So think back to your prep for a procedure where, again, you're going to be getting your consent, NPO after midnight, and prep for procedure. So if they are massively bleeding and you're going to be skipping all that, these patients need to be in the critical care unit. So that's going to be to aggressively treat and stem any bleeding, restore blood volume, and stabilize the cardiovascular system. When bleeding slows or when it becomes more of a chronic issue as opposed to an urgent one, they can be managed in the outpatient or ambulatory setting. The treatment for this is going to focus on stopping the bleeding, of course, and I can't speak today, restoring cardiovascular stability. So again, IV fluids, normal saline, balanced or electrolyte solution, packed RBCs initially, and endoscopic treatments, sclerosing agent, and possibly gastric lavage. So your priority here is going to be initiate the fluids. So if it's a priority type of situation where they're asking you what your nursing priority is, it's going to be your IV solution. Gastric lavage is going to be where they wash out the stomach contents to remove blood from the GI tract, and that's really to help decrease nausea and vomiting, but also to visualize the source of bleeding. So upon admission, your patient's going to be NPO, and that's to prep for the OR or to allow for bowel rest. And if it's for bowel rest, it's going to be up to 24 hours initially, and then you're going to slowly resume that diet. One more thing to note as I'm looking at this PowerPoint, see how it says fresh whole blood or packed RBCs. So initially with an acute GI hemorrhage where it's in the more acute phase and you're trying to restore blood volume, you're going to use the fresh whole blood because they're losing all of their blood products. They're losing everything. Then later, when it's more of a chronic issue, you're going to switch over to the packed red blood cell. That way you're not overloading them with fluid. So your nursing diagnosis are going to be decreased cardiac output, they've lost their blood volume, and impaired tissue integrity because their gastrointestinal tract has been compromised. So you're going to really educate these patients on using over-the-counter medications like their herbals. Think back to the earlier section we talked about garlic and ginkgo, and a couple other ones too that are going to increase bleeding times. NSAIDs, aspirin. NSAIDs are really harsh on the GI tract, and of course aspirin is a blood thinner. So when you're doing your assessment on these patients, collect subjective data. That way you can identify any types of risk factors like aspirin and NSAIDs. So chronic conditions, hypertension, clotting disorders, peptic ulcer disease, chronic hepatitis, alcohol use, cirrhosis, etc. on that one. Physical exam, you're going to assess their cardiovascular status by taking their vitals, get some cardiac monitoring, O2 saturation, and of course color, temp, cap refill, and their mental status. Urine output can be an excellent indicator of cardiovascular status as well. Okay, gastritis. So gastritis, we have an inflammation of the stomach lining. The acute type is more common than the chronic. So you're going to have this more often. And it's caused by a variety of factors. So with acute gastritis, it's generally benign and self-limiting. It's associated with ingestion of gastric irritants such as aspirin, alcohol, caffeine, and foods contaminated with some types of bacteria. So the disruption allows hydrochloric acid and pepsin to come in contact with the gastric tissue, and this affects, this results in irritation, inflammation, and superficial erosion. So the gastric mucosa will rapidly repair itself, which is why it's generally self-limiting, and it resolves and heals within several days. So other things that can cause this can be chemotherapy and radiation. So your manifestations here are going to be anorexia. These patients are not going to want to eat. nausea and vomiting. They might have some hemoptysis where they're vomiting out blood, melena, which is the blood in the stools, abdominal pain, and shock. And it really depends on how severe it is. So the abdominal pain is going to be epigastric. They can have a wide range of these symptoms, and they can be asymptomatic, it can be mild, it can be quite severe. So pretty big range there. Many times pain is minimal if the patient is experiencing erosive gastritis, and that's typically going to be stress-induced. And this is relieved by belching or having a bowel movement. Corrosive gastritis is more severe, and the symptoms are suggested of a perforation. So they might have some severe bleeding, signs of shock, and an acute abdomen. So when I say acute abdomen, they're going to have severe pain. It's going to be rigid. It's going to have a board-like feel to it, especially once perforation occurs. So if this is happening, you should not be palpating the area. So chronic gastritis over on this side, this is unrelated to acute gastritis. It's typically a progressive disorder that begins with superficial inflammation and gradually leads to atrophy and loss of a gastric tissue. This is irreversible, so this is a permanent condition. It's more common in the elderly, chronic alcoholics, and smokers. So there are a couple different types. There's autoimmune gastritis, and then there's the one from H. pylori. So autoimmune is going to be less common, and that accounts for about 10% of your patients with chronic gastritis. This is when the body produces antibodies that affect the gastric mucosal cell, and this results in tissue atrophy and loss of hydrochloric and pepsin secretion. So if you look at the H. pylori, that's going to be a more common form of chronic gastritis. That's caused by chronic infections of the gastric mucosa by H. pylori, which is that gram-negative bacteria. This creates inflammation and thinning of the gastric mucosa. It causes it to be a less effective barrier against the autodigestive properties of hydrochloric acid and pepsin, and that leads to peptic ulcer disease and increased risk for gastric cancer. So your manifestations for chronic gastritis are going to be vague. They're going to have discomfort after eating. They may be asymptomatic. They're going to have signs of anemia and fatigue. They could also have a feeling of heaviness after eating meals, a burning type of epigastric pain that's not relieved by antacids. These patients may have fatigue and other symptoms because of anemia due to blood loss. So if it's autoimmune gastritis, the intrinsic factors are decreased and a vitamin B12 deficiency occurs. You may see paresthesias or other neurological manifestations with these patients. So they're going to perform a gastric analysis where they assess the hydrochloric acid secretion, and that might be decreased in chronic gastritis. H&H and RBCs, they're going to evaluate for the evidence of anemia. They're going to do a testing for H. pylori infection, and this is done doing urea breath tests, serological testing, and fecal antigen testing. They're going to look for some pernicious anemia by running serum vitamin B12 testing, and they can do an upper endo as well. So they're going to be inspecting the gastric mucosa for changes, identify any areas of bleeding, and obtain tissue biopsies. So bleeding sites may be treated with electro or laser coagulation or injecting a sclerosing agent. Okay, so medications here, and like I said earlier when we were talking about meds before, some of these are going to overlap. This is where you're going to see some differences down here. So they're going to do PPIs and H2 antagonists again. They're going to do the Prilosec, the Prevacid, and Protonix. Like I said earlier, Protonix is going to be the most common. And in the hospital setting, we can give this IV. Your patient could be on PO, IV, or even an IV drip of that. So antibiotics, think about your H. pylori type infections. So they're going to do a combination of 2 antibiotics. That's going to be your Flagyl and your amoxicillin or your erythromycin. and then they're going to protect the mucosa. So this is going to be your Carafate here, and these come in pretty big pills, so they're pretty large. They're bigger than a vitamin. You can also get this in a liquid form. So if your patient has trouble with that, I would suggest getting the liquid formulation of that. Other things you're going to do is you're going to promote GI rest by making these patients NPO. When they do get reinitiated on a diet, the order will say to progress as tolerated. That means you're going to start your patient off on clears and progress from there, and then IV fluids to maintain fluid volume status. Keep in mind too, especially as you're prepping these patients for discharge, that there is a big, huge trend in homeopathic therapies and over-the-counter type of things that you would get at a health food store. So some of the patients will prefer to treat their symptoms that way. Just make sure the provider is aware of it, because a lot of people do like to take ginger and cinnamon and coconut water for issues of the GI tract. So here's going to be your nursing diagnosis. So fluid volume deficit, you're going to be getting vitals on these patients, daily weights, BUN and creatinine, monitor INOs, electrolytes, mucous membranes, and skin turgor. So for imbalanced nutrition, also some of the same interventions, so INO, daily weight, dietary consult, think about your dietitians, supplements, and you might want to keep careful track of what these patients are eating. That's not generally in order, but you can always write down patient ate one sandwich and be specific about it. If they have nausea, make sure that you're really calculating your food percentages, give them antiemetics if they're ordered, and encourage small meals, especially with clear liquids to start with. And educate your patients on what to do after they go home. So peptic ulcer disease, this is when we're going to have a break in the mucosal lining of the GI tract where it comes in contact with the gastric juices. So this is going to occur along any region of the GI tract that's exposed to acid and pepsin secretions. Duodenal ulcers are going to be your most common, and these gastric ulcers more often occur in your older adults. And these are linked to people that smoke and use chronic NSAIDs. So H. pylori is going to be the #1 cause of this again. And there it is. And then cigarette smoking, and that's because it inhibits secretion of bicarbonate from the pancreas, and it's potentially leading to a more rapid transit to the duodenum of gastric acids. So H. pylori can spread from person to person, and it's increased prevalence in in areas of low socioeconomic status. So think about your developing countries, your crowded and your unsanitary living conditions, and areas where food and water could be contaminated. So gastric ulcers are associated with increased evidence of gastric cancer, and they may be chronic with remission exacerbations. And the exacerbations may be due to trauma, infections, or stressors. So your manifestations are going to be pain. It's described as gnawing, burning, aching, or hunger-like, and that's going to be in the epigastric region. Sometimes this radiates to the back, and this occurs when the stomach is empty. So think about your pain food relief cycle. So the pain is the classic symptom of peptic ulcer disease, and it is most often identified as first thing in the morning, before meals, and at night. So make sure that when you're doing your cold spa and they tell you right now their pain's 0, that you ask them if they had any pain throughout the course of the day, and then just do a thorough assessment on it to find out the triggers. So in older adults, the symptoms are often vague. They might have some chest pain, they might have dysphagia, weight loss, or anemia. So lots of different types of complications can occur with peptic ulcer disease. Hemorrhage is going to be one of the main ones, and that's due to ulceration and erosion into the blood vessels of the gastric mucosa. They could also be suffering from obstruction, and that's typically in the gastric outlet, and that's from edema surrounding the ulcer, leading to scarring or smooth muscle spasms. And these are going to be more gradual of onset. If they have perforation, that's going to be a medical emergency. The pain is going to be severe. They could have gastric or duodenal contents entering the peritoneum, so that's going to really lead to peritonitis. And a bacterial peritonitis follows in about 6 to 12 hours after gastric contents enter the sterile peritoneal cavity. So this is going to be quite fast. And the signs of this are going to be shock. So think about your diaphoresis, tachycardia, rapid respirations, change in mentation, and you're going to be prepping those patients for emergency surgery. The peritonitis is going to be the most lethal of these if that occurs, and they're going to have severe upper abdominal pain that radiates throughout to their shoulder. And they will also have an acute abdomen, so think about that rigid, hard abdomen again. So this is Zollinger-Ellison syndrome. This is a peptic ulcer disease caused by a gastroma. So you can see the gastroma there. And that can be that's a gastrin secreting tumor of the pancreas, stomach, or intestines. And more than 60% of gastromas are going to be malignant. So gastrin is going to be that hormone that stimulates the secretion of pepsin and hydrochloric acid, and that causes hypersecretion of gastric acid, which in turn creates mucosal ulcerations. So your manifestations of this are going to be ulcer-like pain, diarrhea, and complications from bleeding. They're going to have fluid and electrolyte imbalances because of the diarrhea. So think about your electrolyte panels, so your potassium and your sodium. So gastric analysis is needed to evaluate gastric acid secretion. They're going to aspirate stomach contents through an NG tube, and gastric levels are going to be high in this syndrome. So for diagnostics for these, they're going to do an upper GI series endoscopy with a biopsy. They're going to be looking for H. pylori again with the antigen analysis. You're going to be giving medications again here, and that's going to be to treat and eradicate any infection. So we're going to have our PPI and our H2 antagonists again, our antibiotics to treat any H. pylori infection, and we're going to be protecting that stomach with some Carafate or some bismuth, so your Pepto-Bismol. So you can see, once again, a lot of these medications and treatments are going to overlap. So with nutrition, you want them to have a balanced meals with regular intervals. Bland or restricted diets are no longer necessary. That used to be the recommendation, but that's no longer a common treatment with these patients. Mild alcohol use is okay, but smoking is not. So we no longer restrict them on alcohol as long as it's just a couple drinks. So other treatments, if they're experiencing a hemorrhage, you're going to give them IV fluids, blood transfusion, NG tubes to prevent aspiration from vomiting, and you're going to make them NPO. If they develop into a perforation, IV fluids, NG to suction, Fowler's position, and IV antibiotics, because think about the peritoneal contents that are happening. Surgery is not really common unless there's complications like what we discussed. If they do end up needing surgery, they're going to do a gastric resection on these patients. So your nursing diagnosis, you're going to have pain, so you're going to be assessing for pain, administer your PPIs and H2 antagonists to help with that, as well as your antacids, and teach stress management. For disturbed sleep pattern, you're going to look at education regarding taking a bedtime dose of their PPI if it's ordered, and that's going to help relieve any discomfort. They're going to limit food intake after the evening meal, which means no snack before bedtime, and relaxation techniques to help promote sleep. For imbalanced nutrition, you're going to assess their current diet and their eating schedule and educate them on how food precipitates pain. Refer them to the dietitian and monitor symptoms with intake and monitor their labs. Fluid volume deficit, they're going to have a risk for bleeding, monitor their stools, IV therapy, NGs, H&H, and a thorough abdominal assessment. So stomach cancer, some of the risk factors that you're going to see here are H. pylori again. They could also have a genetic predisposition to gastritis. They could have carcinogenic factors in their diet, like smoked foods, nitrates. That goes back to your meats, bacon, and hot dogs. Smoking places these patients at an increased risk, as well as a history of a partial gastric resection. So these are going to be most frequently found in the distal portion of the stomach. They begin as a localized lesion and then they progress to invade the mucosa and submucosa. There's going to be lymph node involvement possibly when metastasis occurs, and that can happen early due to a rich blood supply. So the adenoid carcinoma form is going to be the most common, and that involves the mucus-producing cells of the stomach. This metastasizes to the lung, liver, ovaries, and the peritoneum. Your manifestations, there's very few. They're going to be vague. They're going to have feelings of early satiety where they feel full soon, anorexic, indigestion, and vomiting. So a lot of times when the manifestations occur with this disease, they're going to be quite advanced, and metastasis is usually present at the time of diagnosis. So for diagnostics, they're going to have a, well, there we go. There's a little slide on the different symptoms. For diagnostics, they're going to have a CBC, an upper GI x-ray, ultrasound, and an upper endoscopy. So the CBC is going to detect any types of anemia. Upper GI, they'll be able to identify lesions or masses. And for the endoscope, they can do a biopsy to get a definitive diagnosis. Your treatment's going to be surgery to do a partial gastrectomy or a total gastrectomy. So a partial is going to be removal of the distal to 2/3 of the stomach, and an anastomosis to the remainder of the stomach directly to the duodenum or the jejunum. A total is going to involve the entire removal of the stomach, and the anastomosis is going to be from the esophagus to the duodenum or jejunum. These patients are going to suffer from dumping syndrome. They're going to have hypertonic, undigested food boluses that may rapidly enter the duodenum and jejunum. So really think about peristalsis being stimulated, and intestinal motility is going to be increased. They're going to have nausea, vomiting, epigastric pain with cramping, and diarrhea. So your nursing management with this is going to be to really educate those patients on diet that delays gastric emptying. You're going to increase proteins and fats because they're going to be slower to digest. Low carbs with simple sugars, lay down after meals, and eat liquids and solids at separate times. They might need some anticholinergics and antispasmodics to help with that. So you're really telling them to eat small meals more frequently. You want to anticipate grieving with these patients. They may have a G-tube and quite a few uncomfortable side effects like what we talked about with the dumping syndrome. Okay, that is it for this section. We will have a couple more PowerPoints on upper GI before we hit to lower GI.